Welcome to Weekly Neurology Deep Dive. This deep dive is for educational purposes only, and it offers a summary of clinical and paraclinical characterizations, management, and prognosis in DPPX antibody-associated encephalitis, a systematic review. It is crucial for you to read the complete paper for a thorough understanding. This deep dive focuses on equipping neurologists like you with practical insights for daily clinical practice, all within 15 minutes. Today, we're diving into the often misunderstood world of DPPX antibody-associated encephalitis, or DPPXE. It's a condition that can truly keep.
What makes DPPXE so tricky is that there's no single test to definitively diagnose it. We rely heavily on recognizing patterns and piecing together clinical clues, and even then, the underlying trigger often remains a mystery.
So we're dealing with a bit of a neurological puzzle. What are the pieces we need to be looking for in our patients?
The paper highlights what the authors call the tricky triad of symptoms. About 44% of patients present with this trio, and it's a combination that can initially mislead you toward more common diagnoses. The first element is gastrointestinal distress. We're talking persistent diarrhea, abdominal pain, and often these symptoms start months or even years before any neurological signs appear.
Say a patient might be going through multiple rounds of tests with a gastroenterologist before we even get involved.
Exactly.
It's a long time to be suffering without answers.
The second piece of the puzzle is the presence of cognitive and psychiatric symptoms, things like memory problems, disorientation, hallucinations, and even depression. Now, these symptoms in isolation could point to a number of different conditions, which is why it's so crucial to consider the bigger picture.
It's that third element of the triad, though, that really seems to set DPPXE apart from other conditions.
You're spot on. This is where we see the hallmark of DPPXE, CNS hyperexcitability. This can manifest in various ways, from myoclonus, the sudden involuntary muscle jerks, to tremors, and even seizures. But the real red flag, the one that should make you consider DPPXE very seriously, is hyperexplexia.
I have to admit, I'm not as familiar with that term. Could you explain it in a way that really brings it home for us clinicians?
Imagine a patient in your office. You go to lightly tap their knee with a reflex hammer, and they practically leap out of their chair. That's hyperexplexia, an incredibly exaggerated startle reflex, triggered by even the slightest stimuli. These patients are in a heightened state of nervous system activity, reacting intensely to sounds, touches, even sudden movements.
That's a striking image. So if we're seeing this triad, the GI issues,
That's correct.
cognitive and psychiatric changes, and especially that hyperexplexia, our antennas should be going up. But how do we confirm our suspicions? The paper mentioned that some of the standard neurological tests might not be very helpful in diagnosing DPPXE.
That's right. An MRI, for instance, might come back normal or show very subtle, non-specific changes. Only about 42% of patients in the study showed any MRI abnormalities at all. So while imaging can be helpful in ruling out other conditions, it's not the definitive answer in diagnosing DPPXE.
What about a spinal tap? Can that shed more light on what's happening?
A lumbar puncture can be more revealing. In DPPXE, we often see signs of inflammation in the cerebrospinal fluid, things like elevated white blood cells and protein. This points toward an immune system that's gone a bit haywire, however. The gold standard for diagnosing DPPXE is finding those telltale antibodies.
These antibodies are targeting a very specific part of the nervous system.
Absolutely, aren't they? These antibodies are going after the extracellular subunit of the voltage-gated potassium channel 4.2. This channel is critical for regulating nerve cell activity. Imagine it like a gatekeeper, controlling the flow of electrical signals in the brain. When these antibodies latch onto this channel, they disrupt that delicate balance, leading to the neurological symptoms we see in DPPXE.
And the study stressed that we need to test both serum and CSF.
That's a crucial point for these antibodies, correct, to make a reliable diagnosis of DPPXE. Both the serum and CSF need to test positive for these antibodies. Now, the paper did mention some interesting findings about antibody levels. It seems there are differences in levels observed in studies from the US compared to China. The reasons for this variation aren't entirely clear. It could be due to ethnic differences, or perhaps the timing of the testing during the course of the disease.
So it sounds like while we have a good understanding of what to look for with DPPXE, there are still some nuances to the diagnosis. We need to be thorough and consider all the pieces of the puzzle.
That's a great way to put it. DPPXE really does require us to be detectives. But the good news is once we have a confirmed diagnosis, there are effective treatment options available.
That is good news. I think that's a good place to pause for now.
Yes. We can delve into those treatment options in our next segment. Let's explore the treatment landscape for DPPXE. As we touched upon earlier, immunotherapy is the cornerstone of our approach. The key here is early intervention. The sooner we can initiate treatment, the better the chances of a positive outcome for the patient.
What are the most common first-line immunotherapy options for DPPXE?
The study found that intravenous methylprednisolone, a corticosteroid, was the most frequently used first-line treatment, with 92.6% of patients receiving it. The typical dosage was 1,000 milligrams per day for 3 to 5 days, followed by a tapering regimen.
So a pretty aggressive initial approach to dampen down that overactive immune response we were talking about earlier. What other first-line therapies are in our arsenal?
Intravenous immunoglobulin, or IVIG, was used in 45.7% of the cases, typically at a dose of 0.4 grams per kilogram per day for 5 days. Plasma exchange was another option, employed in 40.7% of patients, with 5 to 7 sessions conducted over 7 to 14 days.
It sounds like combination therapies were also common.
That's right. Combining a 5e immunoglobulin with IV methylprednisolone, or using IV methylprednisolone in conjunction with plasma exchange, was quite frequent. Ultimately, the choice of treatment hinges on the individual patient's presentation and their response to the initial therapy.
Now, the paper also delved into second-line immunotherapy options. When do those come into play?
Second-line therapies are considered when those first-line treatments aren't fully effective, or if the patient, unfortunately, experiences a relapse. And the study showed that a significant number of patients, nearly 59% of those receiving immunotherapy, ended up needing second-line treatment.
What are the go-to second-line options for DPPXE?
Rituximab emerged as the most frequently utilized second-line agent. Other options included cyclophosphamide, mycophenolate, and azathioprine.
There was an intriguing finding about rituximab that caught my eye in the study.
Yes, there was a trend, although not statistically significant, suggesting that patients treated with rituximab tended to have better long-term outcomes they were more likely to achieve a modified Rankin scale score of 0 to 2, which indicates a good functional outcome.
That's certainly a point worth noting. Rituximab might prove to be a valuable weapon in our fight against DPPXE, especially for patients who aren't seeing adequate results from those first-line therapies. The study also briefly touched upon maintenance therapy. Is this something routinely recommended for DPPXE patients?
The optimal approach to maintenance therapy in DPPXE is still an area of active discussion and debate in the medical community. There's no clear consensus yet on whether it's necessary for all patients or for how long it should be continued.
So how are we currently approaching maintenance therapy in clinical practice?
The general recommendation, at least for autoimmune encephalitis, and this might also apply to DPPXE, is to initiate long-term immunosuppression, ideally with rituximab, for a duration of approximately 3 years. After that period, the patient's condition can be reevaluated to determine if it's safe to withdraw the immunosuppressive therapy.
So it's a balancing act between preventing those potential relapses while also minimizing the risks associated with long-term immunosuppression.
But it's crucial to underscore that these are just general guidelines. The decision regarding maintenance therapy must be individualized, taking into account the patient's specific circumstances, their risk factors for relapse, and importantly, how they've responded to previous treatments.
Now let's shift gears and talk about that subset of patients who present with DPPXE in the context of an underlying malignancy. This adds another layer of complexity, doesn't it? How does our management strategy change for these individuals?
In these cases, treating the underlying cancer becomes just as critical as addressing the neurological symptoms with immunotherapy. It's a two-pronged approach.
Did the study shed any light on the effectiveness of oncotherapy or cancer treatment in these patients?
The study included 14 patients with concomitant tumors, and 71.4% of them received oncotherapy. The types of oncotherapy employed included chemotherapy, radiotherapy, and surgical tumor resection, depending on the specifics of the case.
And what were the outcomes for these patients who received cancer treatment?
Interestingly, the study found that treating the underlying malignancy was effective in preventing the progression of those neurological deficits we see in DPPXE. It also appeared to improve the overall prognosis for these patients. This highlights the importance of thorough cancer screening during the initial evaluation of any patient suspected of having DPPXE, especially if there are red flags on imaging or if the patient has no risk factors for malignancy.
This really underscores the critical interconnectedness between different medical specialties, doesn't it? Sometimes we can't just focus on the neurological presentation in isolation. we need to consider the patient's overall health and collaborate with our colleagues in other fields to provide the best possible care.
Recognizing that neurological conditions can sometimes need a manifestation of a systemic illness is paramount, and addressing the root cause, in this case, the malignancy, is essential for optimal patient outcomes.
Now that we've laid out the treatment landscape for DPPXE, let's turn our attention to prognosis. What does the long-term outlook look like for patients with this condition?
The good news is that a majority of patients with DPPXE respond well to treatment and have a generally favorable prognosis. Remember, this is a treatable condition.
That's reassuring to hear. Can you give us a sense of just how many patients showed improvement after receiving immunotherapy and/or oncotherapy?
The study found that a significant proportion, nearly 83% of patients who received treatment, saw improvement in their symptoms. However, it's not a universal success story. Approximately 7.4% of patients remain stable, and unfortunately 9.6% continue to decline neurologically, with some cases even resulting in death.
So while the outlook is generally positive, there are still those cases where the disease takes a more challenging course. Were there any factors identified that might predict a poorer prognosis?
Interestingly, the presence of that tricky triad we discussed earlier, the combination of gastrointestinal problems, cognitive psychiatric symptoms, and CNS hyperexcitability was more common in patients who had a worse outcome.
So it seems the more classic the presentation, the more severe the disease tends to be.
That's the suggestion based on this particular study. However, it's important to remember that even patients who present with a severe form of DPPXE can still respond well to treatment. It's not a deterministic factor.
Were there any other indicators associated with a less favorable prognosis?
Yes. The study revealed that patients who, for various reasons, did not receive that crucial first-line treatment were more likely to have a poorer outcome. This finding really emphasizes the importance of early and aggressive intervention when we're dealing with DPPXE.
So time is truly of the essence in these cases. Prompt diagnosis and treatment can make all the difference. What about the possibility of long-term complications? Did this study provide any insights into that aspect?
Unfortunately, some patients did experience long-term sequelae, such as lingering gait instability or persistent cognitive deficits, even after treatment. And while the overall mortality rate was relatively low at around 5.8%, it's a somber reminder that those deaths were often attributed to complications stemming from those neurological symptoms, such as pneumonia secondary to bulbar dysfunction.
That highlights the need for continued vigilance and supportive care, even after the acute phase of the illness has subsided. It's not just about treating the immediate symptoms. It's about managing the long-term impact of DPPXE as well.
Recognizing that DPPXE can have lasting impacts on a patient's life is crucial. We as neurologists need to be prepared to manage those complications and provide comprehensive support throughout their journey.
Let's delve a bit deeper into the issue of relapse, which you mentioned earlier as a concern in DPPXE. What percentage of patients experienced a relapse, and what was the typical time frame for these relapses to occur?
The study reported that approximately 28.7% of the patients experienced at least one relapse. However, it's worth noting that this number might be an underestimate. The follow-up duration varied quite a bit among the patients in the study, and some were lost to follow-up.
So there's a possibility that the true relapse rate could be even higher than what's reported in the study.
That's a distinct possibility, especially if we consider that some relapses might occur after a longer period of remission. It's something we need to be mindful of.
Did the study reveal any patterns in the timing of those relapses?
Unfortunately, no. There wasn't a specific time frame identified. Relapses could occur relatively soon after the initial treatment, or even years down the line. This really emphasizes the need for ongoing vigilance and long-term follow-up with these patients. We can't just assume they're cured after the initial treatment.
We've covered a lot of ground in our discussion of DPPXE today, from the initial presentation, diagnostic challenges, to the various treatment options and the long-term outlook for these patients. What are your final thoughts on this condition? And what's the most crucial message you'd like to leave with our fellow neurologists?
DPPXE is a truly fascinating and at times perplexing condition. It serves as a stark reminder that neurology is rarely straightforward. We need to be sharp, observant clinicians, paying attention to those seemingly subtle clues, and always considering those less common diagnoses, especially when faced with a complex clinical picture. The good news is, as we've discussed, DPPXE is treatable. Most patients can achieve a positive outcome if they intervene early and appropriately.
However,
we must remain vigilant. Relapses can happen, and long-term monitoring is absolutely essential.
This has been an incredibly insightful discussion. Before we wrap up our deep dive into DPPXE, let's take a moment to reflect on what we've learned. For those of you listening, what are your key takeaways from our conversation today? What aspects of DPPXE do you find particularly intriguing or challenging? We'll continue our exploration of DPPXE in our final segment, tackling some of those unanswered questions and pondering the future directions for research and clinical practice. This fascinating field. As we wrap up our deep dive into DPPXE, let's explore some of the unanswered questions that still linger in this complex condition. Despite the progress we've made, there's still much we don't know.
One of the most significant mysteries surrounding DPPXE is pinpointing its root cause. While we've identified potential triggers, like viral infections and certain medications, the underlying mechanism that leads to the production of these DPPX antibodies remains elusive in many cases. It's like having a puzzle with some pieces missing.
So we're still searching for that missing link. That explains why the immune system
goes awry in these patients. We need more research to unravel the immunological pathways involved and to understand why some individuals develop DPPXE while others exposed to the same triggers don't. It's a complex interplay of factors that we're still trying to decipher.
Another area that seems ripe for further investigation is the relationship between antibody levels and disease severity, or the likelihood of relapse. We know that both serum and CSF need to be positive for those DPPX antibodies to make a confident diagnosis. But does the level of those antibodies tell us anything about the course the disease might take?
That's a great question, and unfortunately, one that we don't have a clear answer to yet. We need more data to determine whether higher antibody levels correlate with a worse prognosis or a higher risk of relapse. This information would be invaluable in guiding treatment decisions and providing more accurate prognostic information to our patients.
It would also be incredibly helpful to have a standardized cutoff for antibody levels to create more uniformity in
diagnosing and managing DPPXE across different healthcare settings. I couldn't agree more. Having that clear benchmark would make a significant difference in clinical practice. And while immunotherapy has proven to be generally effective in treating DPPXE, we still need more research to define the optimal treatment protocols. This study highlighted a potential advantage of using rituximab, but further studies are needed to solidify this finding and establish clear guidelines for its use.
The question of maintenance therapy is another area.
Absolutely, where more definitive recommendations would be welcomed. Currently, the decision to implement maintenance therapy, and for how long, is largely based on expert opinion and extrapolated guidelines from other autoimmune encephalitis. Large-scale prospective studies are needed to provide more concrete evidence to guide our decisions and ensure we're providing the best possible long-term care for our patients.
The study also hinted at some potential differences in entity, clinical presentation, and antibody levels between patients from different ethnic backgrounds. Is there any ongoing research?
That's an intriguing observation, exploring these potential variations, and one that definitely warrants further investigation. If there are true ethnic or geographic variations in DPPXE, that could have significant implications for diagnosis and treatment strategies tailored to specific populations. More research in this area is crucial to address potential disparities in care.
And of course, we can't forget about that subset of patients who present with DPPXE in the setting of an underlying malignancy. What are the pressing research needs in this area?
Understanding the intricate link between DPPXE and cancer is a top priority. Are certain types of cancer more prone to triggering DPPXE? What are the most effective strategies for managing both the neurological and oncological aspects of these cases simultaneously? These are some of the questions that researchers are actively exploring.
It seems we've only just begun to scratch the surface. In our understanding of DPPXE, what's the key takeaway you'd like to leave our listeners with today?
DPPXE is a rare but very treatable disease that can profoundly impact a patient's quality of life. For neurologists, it's paramount to be aware of this condition, recognize its often subtle warning signs, and initiate prompt treatment. While we've made significant strides in our understanding of DPPXE, continued research is essential to fill those remaining knowledge gaps and ultimately improve the lives of those affected by this challenging condition.
This deep dive into DPPXE has been truly illuminating. We've covered a vast landscape, from the intricacies of diagnosis to the nuances of treatment and the ongoing quest to unravel the mysteries surrounding this complex condition. For our listeners, we encourage you to explore the full research paper and continue your journey into the fascinating world of DPPXE. Until next time, keep those brains engaged and those minds curious.